Hi, my name is Samuel Samron. I'm a urologist here at Brown Urology, and I'm here to review prostate cancer information, treatment options, and things to think about with you. Prostate cancer is one of the most common cancers that affects men in the United States. In fact, almost 250,000 men are affected by prostate cancer every year. Fortunately, a much smaller number of men die of prostate cancer every year, only 15,000. So that tells us that not all prostate cancers are the same. And in fact, there is a whole spectrum of prostate cancer, some of which does not need to be treated and just needs to be monitored, some of which needs systemic or whole body type treatment. Fortunately, most people who come in with organ-confined prostate cancer, that is localized prostate cancer. And to help risk stratify those patients, we use 3 important pieces of information. 1, the rectal exam, 2, the PSA, and 3, the Gleason Score. The rectal exam, if it's normal or very minimally abnormal, then that could put you in a low-risk category. If it is more than minimally abnormal to almost, pretty nodular, then it puts you in a medium or intermediate risk category. Whereas if it's severely nodular, then it could be, or woefully abnormal, then it could be in a high risk category. The PSA similarly has those cutoffs, where a PSA less than 10 puts you in a low risk category, 10 to 20 puts you in an intermediate risk category, and greater than 20 puts you at a high risk category. The Gleason Score, which is how the pathologist looks at the slides obtained from the prostate biopsy and how far deviated it is from normal, corresponds to a higher Gleason Score. And while we have a 5-point score, 1 and 2 are actually not cancer. So there's Gleason 3, 4, and 5. And the further abnormal it is, the higher the score is going to be, and the more aggressive it's going to behave. So Gleason 3 plus 3, and what they do is the pathologists, they'll look at the 2 biggest populations in that slide, and then they will add those 2 together to give you the composite score. So Gleason 3 plus 3 is low-risk prostate cancer. Gleason 3 plus 4, or 4 plus 3, is intermediate-risk prostate cancer. And Gleason 4 plus 4 or greater is considered high-risk prostate cancer. Now, the risk stratification is important not only to assess how aggressive this disease may be, but also determines what kind of treatments we should offer. For low-risk prostate cancer, you probably just need either, if it's low volume, active surveillance, or one form of treatment or the other, like surgery or radiation. For intermediate risk prostate cancer, usually surgery or radiation with hormones is enough. However, when you go on to high risk prostate cancer, it's usually surgery and radiation with hormones that is required to treat those high risk cancers. Just a word about focal therapy. Focal therapy has been published upon a lot recently. There's a lot of interest in trying to spare treatment of the whole prostate gland in an effort to minimize the side effects. I think we could refer you to a center that has a clinical trial if you're interested, but the data so far doesn't necessarily support doing focal therapy outside of the setting of a clinical trial, and there are several criteria that need to be met for you to consider focal therapy, such as intermediate risk disease localized in only one area of the prostate, as deemed by both MRI and biopsy. And so the mainstay of prostate cancer treatment is whole gland therapy. We treat the whole gland. And how do we treat the whole gland? Either with surgery or radiation. Now, I'm a surgeon and I'm biased towards my approach towards surgery. but there's good data to support that surgery is better than radiation in the following reasons, or for the following reasons. Number one, you get additional pathology. So if you were to do radiation, those 12 needle biopsies that you got would be the last bit of pathologic information that you would get. Whereas if you did surgery, if we did prostatectomy and lymph nodes, all that tissue would be sent off to the pathologist and analyzed. And sometimes what happens is the pathology on the final specimen is different or discordant than the pathology on the biopsies. And that can change the management. Two, the performance of the PSA is better in the post-prostatectomy setting. When you do a radical prostatectomy, the PSA should go from whatever elevated number it is down to 0 or undetectable. And should it start creeping back up, that's a pretty accurate sign that you have prostate cancer coming back again. If you were to undergo radiation, what happens is the PSA climbs up, there's a PSA bounce, and then it drops down to some low number, and then at that point there's always some variation, a little bit of up and down, and that's a bit of noise with the PSA performance. It is hard to tell exactly when someone should be concerned about the PSA after radiation. In fact, there are a couple different definitions out there to define biochemical recurrence after radiation. So one group has proposed 3 consecutive rises. Another group, and I think that's the more commonly used definition, is the nadir. The lowest the PSA goes plus 2. 3, surgery is better than radiation because in long-term data, surgery offers better cancer control. So surgery and radiation are probably equivalent for 10 years. But beyond 10 years, the rate of recurrence is lower in men who undergo surgery. So if you are in your late 70s, that may not matter. That may not be that important. But if you're a younger gentleman looking to have a very long-term cancer-specific survival or living and not dying of the prostate cancer, surgery may give you that longer-term benefit. The last reason why surgery may be better than radiation is because when we do surgery, and should there be, God forbid, worse disease than we anticipate that necessitates a second line of treatment, or should there be a biochemical recurrence that means the PSA climbs up and you need a second line of treatment, it is much easier to give radiation to that area instead of doing it the other way around. A lot of people will say that doing surgery on a prostate after it had been irradiated is impossible. It's not impossible, but it's just much more difficult. One, the tissues are much more stuck, making the surgery more difficult. But more importantly, two, there's a reconstructive aspect to the prostatectomy. When we take out the prostate, we have to connect the bladder neck to the urethra, and we sew that together. In doing so, that area needs to heal up, and healthy tissues heal well. Unhealthy tissues, like those that are irradiated, do not heal well. And so, in my biased opinion, surgery is superior for a lot of patients than radiation. How do we do the surgery? Well, I do it robotically. That's my area of expertise. What we do is we give you general anesthesia, so you don't feel or remember a thing. We'll lay you with your head down and feet up so that all your bowels move out of the way. We fill your belly up with carbon dioxide gas in order to give us space, and we put 6 small poke holes in the belly. Through those poke holes, we're able to put our camera and instruments. The camera gives us 10 times magnification and 3D visualization. I sit at a console, not 10 feet away from you, and my hand motions are translated to the robot's hand motions in a scaled and tremor-free fashion. This allows me to do precise work in a narrow area like the male pelvis. We'll dissect out everything that's around the prostate, separate it from the bladder neck, separate it from the urethra, dissect it off of the rectum, cut its blood supply, and then we reconnect the bladder neck to the urethra. The surgery itself takes 2 or 3 hours. We will leave a Foley catheter in between that connection in order to not stress out that connection. We'll also leave a drain alongside that connection to make sure that if there's any leakage, we are aware of it. It is very rare for a patient to go home with a drain. We'll leave a Foley catheter in for a week, at which point you would come back, have the catheter removed, and we would go over your pathology. There are risks of the surgery, and there are side effects of the surgery. The risks of surgery are like any other surgery. Risks are bleeding, infection, damage to the nearby structures. There's cardiovascular risks. There's risks of getting a hernia. Fortunately, the risks of any major complication with a radical prostatectomy are very low. Transfusion risks also, if you need a blood transfusion, is on the order of 1%. The side effects of the surgery, however, are 3. 1, prostate cancer could come back. And so it is important to check the PSA periodically after the surgery, basically for the rest of your life. And usually it's more frequently early on and gets spaced out. So one such strategy would be every 3 months for a year, every 6 months for the second year, and then yearly thereafter. The second side effect is urinary incontinence. Urinary incontinence means you cannot control your urine, and that happens to everybody who has this surgery. The reason why it happens is because we take out the prostate, which acts like a dam for the urinary system, and makes your external pelvic floor muscles weak. And so now that we've removed this prostate and the internal sphincter, which is the bladder neck, you have to rely on that external pelvic floor muscle to keep you dry. So doing Kegel exercises from now, even before your surgery, can be beneficial to giving you continence. Also, several surgical techniques are important for helping with urinary continence. If we spare the nerves, that may help. If we leave a long urethra, that may help. If we don't take such a wide bladder neck, all those things matter. And so we do our best to achieve those if the cancer operation allows it. Fortunately, 95% of men will regain continence, but it may take 6 to 12 months. If you're in the unfortunate 5% of people who do not regain continence by 6 to 12 months, you may need a secondary surgical procedure, one as much smaller than a prostatectomy, to render you dry. So one strategy for people with mild incontinence would be to put in a piece of mesh tape or sling, and that can help give you enough resistance that you don't leak urine. The other strategy for people with moderate to severe urinary incontinence is to put in a little hydraulic sleeve around the urethra. And that sleeve will tighten up around the urethra and clamp it off. It is controlled with a pump that is placed in the scrotum. And when you want to go urinate, you will squeeze on the pump that's in the scrotum. That will open up the sleeve, allow you to urinate, and the saline or the water that's in it will cycle right back into the sleeve and close it off. The third side effect is erectile dysfunction. The nerves that control your erections run right alongside the prostate, and nerve sparing can be performed if it is prudent to do so from a cancer perspective. And so if there isn't high-risk disease or high-volume disease on one side concerning for extracapsular extension or extension to where the nerves are, then shaving very close to the prostate and sparing that neurovascular bundle is feasible and can help save erectile function. Unfortunately, sometimes patients have advanced disease or concern for extracapsular extension on one side or both sides. In that case, it is not prudent to do nerve sparing. Nonetheless, after surgery, it will take some time for you to get return of erections if nerve sparing was performed. After surgery, you can try to take medications like Viagra or Cialis. If those don't work, there's a suppository that can be placed in the penis. If that doesn't work, there's an injection, kind of like how diabetics give themselves insulin injections in the belly. There can be an injection that's placed into the side of the penis in order to give you an erection. There's also non-pharmacologic methods of getting an erection, like a vacuum erectile device or a balloon pump prosthesis. We can basically get you an erection. It just depends how far you want to go. And so I hope I have reviewed the risk stratifications, the treatment strategies of prostate cancer. I have reviewed the benefits that surgery may offer over radiation in certain cases, and I've gone over the risks of surgery and the side effects of surgery. I look forward to meeting you and discussing more with you about prostate cancer. Thank you.